4 million Americans suffer from neuropathic pain. With the skyrocketing number of newly identified diabetics, this number will accelerate over the next decade. The principal symptom? Pain with no benefit or purpose. Infection, chronic inflammation, drugs, trauma, diabetes, cancer, and immune deficiency diseases are common causes.
The nerves themselves fire spontaneously with or without any specific nociceptive input.
The core problem lies here with a nociceptor. Designed to warn the brain with an acute response to heat, pressure, or sharpness, the nociceptor is altered in neuropathies. Here's how. This is a normal pain signal from a sharp object, such as a piece of glass. The sensation travels up afferent neurons to the dorsal root ganglion and brain, beginning with the dermis at the level of the nociceptor. In a neuropathy, this peripheral pain receptor is modified so it becomes much more sensitive to pain, transmitting impulses up the afferent neuron with greatly diminished input or none at all, but magnified power, duration, and frequency. And there's more to add insult to injury. Damaged tissue produced the prostaglandin PGE2 via the arachidonic acid pain pathway as lymphocytes, monocytes, macrophages, and granulocytes move into the area of inflammation or infection and secrete a wide variety of substances that bathe the nociceptor to further increase the sensitivity. The nociceptor then becomes much more sensitive to pain impulses. It also expresses new receptors such as the NMDA, which increases the number along local nociceptors and in the surrounding area. And it's not just new receptors. New sodium channels are activated along the neuron, which may release spontaneous impulses. This is what an effective blockade to treat neuropathies looks like. Here is the nociceptor, which senses pain and transmits it to the central nervous system. Inflammatory mediators stimulate the neuron to fire more easily and with greater amplitude and duration. Diclofenac targets the production of these mediators, including the most powerful PGE2, while baclofen potentiates. Ketamine, gabapentin, nifedipine, and baclofen all increase the threshold for firing by targeting the NMDA and GABA beta receptors. Cyclobenzaprine and tetracaine block the sodium channels. The net effect is a substantial decrease in pain.
Well, when you take an oral medication, it gets absorbed into your circulation, goes all over the place in your body. Only a small proportion gets to the target tissue where you will need the drug to work. When it goes everywhere else, it causes systemic side effects.
Transdermal therapy offers these advantages over systemic therapy. Decreased potential for drug interactions. High concentrations of the drug at the site of injury. Low systemic drug levels. Minimal adverse effects. No need to titrate the dose to tolerability. Safe use of polypharmacy. Safe use of medications with multiple mechanisms of action.
The overall advantage of transdermal therapy is that you can combine different classes of medications, the anti-neuropathic medications, the local anesthetics, medications that reduce the perception of pain and deliver them much deeper into the tissues where the pain generator is.
To learn more about transdermal therapy and neuropathies, visit the Transdermal Therapy website. There's lots more information. Thanks so much for watching.